As Louise was speaking, it reminded me, when we were both medical students and David Barker was publishing his hypothesis, there were also colleagues in the university and the NHS looking at the social patterns of birth weight, thinking of what David Barker was thinking of at the time. And I got directed towards some data that on the Wirral, there had been collection of data over many years from health visitors. And might we look at those data differently? Iain, you're good with numbers. Can you please go over to the Wirral? I eventually ended up being a junior doctor of a daytime and crunching numbers of a nighttime on the Wirral. And in those data over 20 years, they've been used for no other purpose. There were the signals of excess weight gain between ages 2 and 3 and 9 months and 3 years. So very early signals when a child doesn't have a lot of control over their own food choices and food environment, that we had an impending obesity epidemic. Published it at the time in the BMJ to raised eyebrows of, I'm not sure that there really is that signal. And at the same time, the WHO said, actually, there's an early sign there coming from Liverpool city region of something we recognize as a global problem. Routinely collected data, and this is what we want to do in the C-GULL birth cohort, to make that great participation of our communities in the cohort directly, of our care professionals in the work they do for the cohort, but all the amazing work that goes into curating the data as part of our NHS. Can we harness that to understand the journeys of the child growing up in a connected world where the digital twin of the child will have opportunities if we make them and if we understand them. So I want to talk about that connectedness, but particularly bring it back to many of us have great motivations of tackling inequalities. There's some slides here by our co-investigator, David Taylor Robinson, looking at infant mortality. It's a stain on any developed part of the world to have rising infant mortality. It's a stain on the poverty that can ensue in a relatively wealthy nation. And this was a motivator for the birth cohort. To see rising infant mortality at the time we put this grant together in Liverpool was quite shocking and deeply motivating for us to understand what was going on. A lot is talked about biopsychosocial mechanisms, people trying to dig in to how disadvantage gets under the skin. How does it lead to the diseases that Louise described? Here are the headlines. So as a public health doctor, I look at the fingerprints profile of any area and see how does that compare with other areas. And the bits that flag up in red, if I look at the latest profiles, public health profiles for Liverpool, and that relate to children, smoking in early pregnancy is much higher, almost double. Healthy life expectancy. Now, this is healthy life expectancy. This harks back what Louise was pointing out. The benefits of the last 50 years of improved life expectancy have accrued more in men than women in many circumstances. And you see in Liverpool, but not in all of England, healthy life expectancy actually slightly lower for women than for men, even though the women are living longer. It's another reflection of disadvantage and how that can manifest. School readiness, very, very poor educational attainment, huge headroom for improvement in Liverpool. And this flashes red compared with other areas. 16 times more children in care. Mental health conditions, if we look by age 11, we see rising, escalating mental health conditions reported, but they're only the ones we know about. Our estimate is actually higher than this. Obesity, similarly, higher levels in Liverpool compared with the rest of England. And sadly, around a third of our children are born into poverty, and the absolute poverty figures here showing over a fifth in Liverpool, much higher levels in low-income families across childhood than in other parts of England. So this gets under the skin. It gets under the skin throughout generations, and this slide we deliberately use time and time again. This is a study area, particularly of David Taylor Robinson colleagues in public health, to think of what is that chain of events of disadvantage that may start in very early life, the exposures in the womb that Louise has described so well, but then throughout childhood, in the developmental opportunities that often lead into poor learning. And that leads again to the parenting cycle, to a loop of disadvantage that locks in that poverty and ill health in a vicious cycle. Can we turn that around by tapping into it? Can we actually use routine data to spot disadvantage and poor trajectories early and connect that to opportunities to act? We'll start with our raw data that comes into the birth cohort. So you'll be busy collecting forms, and there'll be research data. We have our civic data cooperative, I think we're represented in the room, some great work going on to think of how do we pull the data together so that for many years to come, they'll be very well described, they'll be cleaned up, linked together, and made available in a research-ready form. Now, I mentioned the health visiting data on the Wirral, just how important they were. Imagine if all of the sources of a child's journey growing up, all of the relevant sources of data were brought together securely so that the identity of the child and family were never revealed. The people who study data science are protecting the digital twin of the child alongside those studying birth cohorts, thinking of how can we give kids a better start in life. Well, that's the technical group that's coming together, and they're very motivated by building this resource for the world. It's not just about data plumbing. So our data science here, we have a civic data cooperative. We deliberately have a cooperative with the community. How do we make the data of the people of Liverpool work harder for the people of Liverpool? And what does that really mean at grassroots level? We don't just want to take what are in standard databases. This city region is a profoundly collaborative place. I have worked in different parts of the country, and there are not many places you could do this, which is to gather from local communities at street level information about the environment for families in that street, and then bring that street level data into routine sources. It's useful for those communities who want to use the data to develop, to say, yes, we will take this grant here, and this is how we will improve. So you have metrics at street level, mobilizing data for the good of communities is moving faster in Liverpool city region than other parts of the country, and indeed many other parts of the world. So this is a pleasure to see this initiative with the Civic Data Cooperative and the One Halton partnership here actually crowdsourcing some of that early environment information of the child growing up, but at street level. Sometimes you have to get great data by giving something back in a very concrete way. So the same data capture from the Civic Data Cooperative here is running challenges to local charities and businesses to better use data to give communities opportunities. There was recently a challenge put out, the What's Your Problem competition, with small grants for groups in areas that were highlighted. After working with communities, 3 areas are highlighted. Increasing family support to stop children entering care was one of those 3 areas. A charity responded, Koala, and they want to look at the first 1,000 days and how do you make it normal to for a family who are running into problems to overcome the stigma around struggling and ask for help. If we reduce that stigma, we can also use connected, we can have a social license for using the connected data more. But that permission, that invitation to use data on might we be struggling, has to come from the communities themselves. So working here with Koala and the Civic Data Co-op is a really important part of getting that permission and engagement. For the data that are already in, you may have seen some fairly big activity in Liverpool in the pandemic. But this is a data culture that is manifest in trust. On the right here, you see work that's been done actually over many years in the Data Saves Lives campaign to give a voice to patients and communities to make their data work for a better health service, for better public health service, with better job opportunities in a local area. And in the pandemic, we saw data mobilized. Here are real-time dashboards on the left, actually more than 17 million test results for COVID. Actually represents a natural cohort of 2.7 million people of Cheshire and Merseyside, which is the most detailed COVID testing cohort now that's been socially characterized that we know of in the world. Indeed, a lot of useful publications are coming out of this. Putting data to work at pandemic pace has also made people think really hard about going from people to data and the permissions, the what's your problem competition I described, alongside the actions you will take on the basis of the data. Great research and discovery is a really important action when we have so many children growing up in poverty and we do not know how that leads to disease mechanisms. We can't act if we don't know. Actions we had to take at pandemic pace showed the data saving lives, saving livelihoods, creating opportunities, including dealing with the difficult risk balance of not just controlling a virus, but controlling the loss of mental health, social development, social fabric from being able to mix together. So how could we open up sooner? What was that balance of risk that did the best for our communities with the data that we had? There's a plumbing diagram here, but let me keep this to the simple concepts are really important. Liverpool's created a blueprint for using data that make everyone's journey a cohort. If we have lots of linked data, we hear about NHS integrated care systems at the moment, GP, hospital, public health data, all coming together. And they reveal a journey. And we live in a connected world where your devices might have notification about screening, about a repeat prescription, about booking GP appointment. It becomes more normal to have the rhythms of your life revealed in a conversation you have with the NHS. So embedding research, like the C-GULL birth cohort, in our NHS, to be at the heart of that is really important. This, I've just come from another meeting actually with the data leads for the NHS, who are really interested in how the data action gap has been closed. How has Liverpool managed to do so much in the past 2 years to act on the data, not just bring data together, but actually deliver benefits from that? And this blueprint gives us the data flows, but also the permissions to bring that into a very, very detailed collection of journeys, digital journeys, of those digital twins of 10,000 children growing up in Liverpool. Let me make this concrete again on actions. So, a colleague in neurology called me the other week and said, Iain, you've got the Cypher system, you're working with that for research, you can analyse at population level on anonymised data. He says, that's great, but I've just had something sent with a list of with a number of patients who haven't been seen recently and are taking valproate. So sodium valproate, 1 in 100 people have epilepsy. A third of those people rely on valproate to stop them having potentially life-threatening seizures. There are 50,000 of those people in Cheshire and Merseyside. Women of childbearing potential had been identified by a national data search, the information given to neurologists, but they couldn't do anything about it because they couldn't identify. But the Cypher system can. So that's one of the fast-track things we're doing now. Stand up the dashboard so that a nurse looking at the call recall to that clinic can see who's not had the reminder recently, and then work with those women to say, would you mind receiving a text message if you're on valproate, just about reminders of the risk of pregnancy being quite high, particularly if you've got a higher dose of the drugs. A quarter, sadly, of those births will have neural tube defects, spina bifida and related conditions. But more than a third will have lower IQ. Now that's a big effect that'll last a lifetime. MHRA are considering withdrawing that drug. That could lead to the deaths of lots of women who rely on the drug for epilepsy. This is another risk balance situation where the data tell us how to balance those risks. So we've talked a lot. If I cast back from medical school junior doctor days to today, there's been this sequence of clinical governance, audit, making clinical audit, using your data to improve services was all the rage in the 1990s. Then in the 10s, there was a lot of talk about learning health systems in a very theoretical way. But bang, we strike a pandemic. And my goodness, it had to go online. We had to use the data. And we need to be resilient. We need to be able to see how to target resources. We need to look at the signals on a daily basis, not on a monthly basis of quality improvement, which just about reports, and people forget by the time they've implemented a slight change. A flywheel effect of continuous learning is now a reality in connected data systems, where you're commissioning small changes to systems instead of writing a long report and implementing it over a long time. You're seeing what works and improving a little by little all the time. You get pace into it. And that's quite exciting. I've seen a buzz in a lot of colleagues in the NHS around what's been done with Cypher. Everyone has their part in this. Back in the science lab, okay, let's say we got these huge anonymized data collections. Is that job done? Do we just need to put a pipe into Liverpool, drain it into a national database, and put some data scientists at the end? I think you'll work out the answer's no, from my perspective. From someone who's been digging into advanced methods of computation, spotting structure that might reveal causes of diseases in big data sets, there's a lot of naivety around big data. Big understanding requires a lot of contextual information. So that data action gap, if you're going to act on the data's usually going to be higher quality, and people will understand the strengths and weaknesses of the data. So working really closely with colleagues at the Women's in this birth cohort is going to get us much more than big data. And the metaphor I use is this prism and the doily. If I'm talking about data science to a group of computer scientists, I say, it's not like teaching a robot to walk around a room. It's not an autonomous vehicle machine learning problem. Health data are not an unbiased representation of what's in front of you on the road. There's such huge missingness. There are only tiny snapshots of when we see people in their daily lives. But it's like looking through a prism through a doily at the problem. You really must have to take knowledge and understanding, including frontline practitioner understanding, and encode that in looking to the data and then re-looking when you think that's not quite right. There's been huge progress in the last couple of years, through a pandemic actually, in how to teach machines to spot causal patterns in data, so-called causal machine learning, and to understand the conversation of healthcare, putting lots of clinical notes together and being able to extract meaning. These methods are becoming incredibly powerful. And Liverpool, by having a deep relationship with this data action, closing the data action gap, will be one of the best places in the world to develop these technologies better. If we can bring that sort of investment into the city, we'll also give the digital twins of those 10,000 babies growing up more opportunities. The future, I say a connected world. If your needs are increasingly predicted by how you interact, your digital twin, there's an awful lot of information on your smartphones about what you might want or need next. The more services people can buy, the more advantage they may have. Given the importance of the first 1,000 days and then the educational journey of children, there's huge potential for increasing inequalities in the augmented versus the unaugmented digital twin of the child growing up. And by looking ahead at what might be and studying a birth cohort at the same time, we will be able to shine a light on those potential inequalities in a connected world and hold a mirror back to those developing, sometimes irresponsible AIs to make them more responsible. So, the story is to be continued. Please get in touch if you have any questions, and I really look forward to this journey. Thank you for listening.